I think a lot of times patients avoid seeing a genetic counselor or talking about genetics. Sometimes it's a misunderstanding. I don't know how this will help me. I don't know how it will benefit me. And I think sometimes it's fear, right? I don't know what they're going to tell me. I think there's a kind of a conception in the public that genetics is your destiny. If I do your genetic testing for cancer risk, I'm going to tell you exactly what kind of cancer you're going to get, when you're going to get it, and what's going to happen with that. And that is not at all what I can do. What I can do is tell you, well, in these remaining years of your life, you have X% chance for these types of cancers. And we're going to recommend we do these screenings to hopefully have as early a diagnosis as possible. There are maybe one gene that I would say has a pretty much 100% chance for cancer. But other than that, it's really more about risks and understanding and hopefully trying to mitigate those as much as we can. And that's it.
Thank you, everybody. My name is Andrew. I'm one of the GI surgeons. I work with Dr. Pimiento. I'll be expanding a little bit on what Laura's just talking about with genetic gastric cancer, and specifically how is prophylactic surgery for inherited gastric cancer a little different, or what kinds of things do we think about in this particular situation? So hereditary diffuse gastric cancer, primarily going to talk about patients with a CDH1 mutation. We are starting to think now that there are actually some other mutations that result in the same syndrome of hereditary diffuse gastric cancer. There's one called alpha-catenin that we're learning about now, but primarily what we talk about is patients with CDH1 mutation. So backtrack for just a second. If you, let's say you have you have gastric cancer and you're looking at your medical records and your pathology report, and you see that it says you have diffuse gastric cancer. So you're going to ask yourself, does that mean that I have hereditary diffuse gastric cancer, if that's what the name of this is? And the answer to that is no. There is diffuse gastric cancer is not necessarily hereditary. There is intestinal gastric cancer and diffuse gastric cancer. It's basically a pathologic description, but you can get it in a hereditary setting, and that's what the CDH mutation is. So should I get tested if I have a CDH1 mutation? And as Laura was talking about, we'll commonly refer patients who are young or have a suspicious family history for genetic counseling, specifically for testing in that scenario. Another setting where it makes sense to get tested is if you are one of the patients who may not require a total gastrectomy based on where the tumor is located, and we might consider a partial gastrectomy. In that setting, it may make sense to get genetic testing because maybe we really should be doing a total gastrectomy. So this, I'm stealing Laura's slide here, but management of different inherited gastric cancer syndromes. So CDH1 is the one that I'll be primarily talking about in the next few slides. And again, as she mentioned, we do routinely recommend a prophylactic total gastrectomy for patients who have a CDH1 mutation. For patients who are not quite ready for that, or they are declining that, they don't feel like they want to proceed with a total gastrectomy, the alternative that we offer is a screening endoscopy every 6 to 12 months with random biopsies throughout the stomach. So if you have a CDH1 mutation, you might ask yourself, why do I need a total gastrectomy? Do I really need to take the whole stomach out? Unfortunately, the answer is yes, because the entire stomach lining is at risk for developing gastric cancer. So shown in this picture, this is the anatomy, as Dr. Pimiento previously described, of a total gastrectomy and how we reconstruct everything after the whole stomach is removed. At the time of surgery, we send both ends of the resection, the proximal end and the distal end, and we have the pathologist look at it under the microscope. And they make sure that they see esophageal lining at this end and intestinal lining at this end to make sure that all of the stomach cells are removed, and we've removed all of the at-risk tissue. Furthermore, when we do a total gastrectomy, even in settings where we think it's prophylactic and we don't think you have a pre-existing gastric cancer, a lot of the time, in fact, maybe most of the time, we will find microscopic cancer cells in the final pathology. So we didn't think that you had gastric cancer going in, but we find multiple different sites of microscopic cancer afterwards. So hereditary diffuse gastric cancer care, CDH1 care at Moffitt. So why choose Moffitt? So coordination of care is extremely important for patients with the CDH1 mutation, and that's kind of why we're all here today. This picture is basically just to show kind of all of the different parties and everybody involved, and we're all talking about you, we're all discussing your cases. We have a weekly gastroesophageal tumor board where we discuss kind of all of the things that we need to be thinking about and making sure that we're not missing anything. And it's really all centered around you. It's all patient-centered care. And we're making sure that everything that we're doing with all of these different parties involved is really according to national guidelines that have been put forth by the National Comprehensive Cancer Network and the International Gastric Cancer Linkage Consortium. And for these reasons, there's a short list of groups or hospitals that are kind of recognized by the Hereditary Diffuse Gastric Cancer Advocacy Group, and Moffitt is among that group. So what is our approach to prophylactic surgery? We perform a thorough pre-surgical evaluation before we embark on a total gastrectomy to assess for any presence of underlying cancer. In other words, are we doing this surgery really prophylactically, or do you actually have cancer that we haven't detected yet? In which case we kind of need to reset, and we're not undertaking a prophylactic approach, we're undertaking a therapeutic approach. So we do that by performing endoscopy prior to your operation with random biopsies throughout the stomach. And then we also perform abdominal CT to make sure that we're not missing anything that we are unaware of. If you've had your CT scans or imaging done elsewhere, we have formal radiology review of those images. Additionally, we do dedicated breast imaging and make sure that we're all up to date, because not only are you at risk for gastric cancer, you're at significant risk for lobular breast cancer as well. As we were undergoing a major operation with significant lifestyle changes after the operation, and you don't currently have cancer that we know about, and it's important that we perform preoperative counseling with our nutritionists and with us and kind of with everybody to talk about the lifestyle changes to expect and kind of how your life is going to be a new normal. Dr. Pimiento and I really think that minimally invasive approach to total gastrectomy is important, and this is really to optimize your recovery and get you back on your feet and get you back to your normal life. And lastly, as I mentioned previously, we coordinate with our pathologists to perform intraoperative testing to really make sure that all of the at-risk gastric tissue is gone, to make sure that there's no residual stomach lining at the top of the stomach or the bottom, just to make sure that there's nothing that's at risk of coming back there. So prophylactic surgery for CDH1 mutation, when do we do it? So we consider this as early as age 20, but there's no hard set rule really. We got to consider that the average age of cancer diagnosis for somebody with a CDH1 mutation, if they are going to get gastric cancer, is 38. But we also consider your family history. As Laura was mentioning, it's not the same for everyone. If you are somebody who has a CDH1 mutation and you know that your family members had a gastric cancer diagnosed in their 40s or 50s, we should probably think about doing this operation sooner. If you're somebody who's has no significant or has no family history of gastric cancer, I think we have some more time. It's important that we coordinate this with all of your other needs. The one that's kind of most that comes to mind most at the forefront of everything is how does this coordinate with your breast prophylactic surgery if you have not had a bilateral mastectomy. Lastly, really when you are ready, when we've checked all our boxes and you've discussed with everybody and you kind of feel that you are ready to proceed with the next step, that's when we're planning on proceeding with that major operation and kind of embracing your new life. Thank you.
Next up, I would like to invite our survivors to come and share their stories. First up, I'd like to invite Yoli Day to share her story, and then she has a friend who's accompanying her as well. So maybe they both can share their stories, after which we'll have Pamela Hall go next.